Good afternoon, everyone. My name is Dr. Surbhi. I'm junior resident in the Department of Psychiatry, and today I will be presenting my seminar on the topic of treatment-resistant schizophrenia, past, present, and future perspectives. We'll be covering this topic under these headings. We'll be talking about the definition of treatment-resistant schizophrenia, then the features, how to diagnose it, the past perspectives, the current management, the challenges that the current management is facing, the future prospects, and in the end, I will be summarizing followed by my references. Now, the definition of treatment-resistant schizophrenia. As per the NICE guidelines, which are followed throughout the Europe as well as Australia, they say that schizophrenia that has not responded adequately to treatment with at least 2 different antipsychotic drugs at an adequate dose for an adequate duration. Usually the duration is taken to be at least somewhere between 4 to 6 weeks. And as per the American Psychiatric Association guidelines, they define treatment-resistant schizophrenia as persistence of moderate to severe symptoms of schizophrenia despite adequate trials of 2 different antipsychotic medications from different chemical classes, at least one of which is second generation atypical antipsychotic at adequate doses and duration, which is again a minimum of 6 weeks. This is quite similar to the definition which the Indian Psychiatric Society also follows. Now talking about the Keynes criteria, so Keynes criteria was given by Dr. John M. Kane, who basically gave this criteria to standardize the diagnosis of treatment-resistant schizophrenia. So this is a 3-dimensional criteria based on the progression. As much as we started understanding treatment-resistant schizophrenia, he started adding dimensions to it. So first is the historical criteria, which was that the patient must have documented history of a poor response to at least 3 different antipsychotic medications from at least 2 different chemical classes. These medications must have been taken at adequate doses, which is equivalent to at least 1000 milligram per day of chlorpromazine for a sufficient duration, which is at least 6 weeks. There should be no period of good functioning within the preceding 5 years. Then the actual criteria, which is somewhere quite closer to the one that we follow currently also. The patient must currently have significant symptoms as indicated by a score of at least 45 on the brief psychiatric rating score. They must also have scores of at least 4 on 2 of the following BPRS items, like the conceptual disorganization, suspiciousness, hallucinatory behavior, unusual thought content. The patient's clinical global impression, which is the CGI, severity score should be 4 or higher, which is moderately ill or worse. And the prospective criteria is that the patient must have failed to show significant improvement after a 6-week trial of haloperidol, which is up to 60 mg per day or higher. Improvement is defined as either a 20% reduction in the BPRS score compared to the level defined by the actual criteria, a post-treatment CGI score of 3 or less, a post-treatment BPRS score of 35 or less. So this is the Crane criteria. This is widely used and accepted, but there are shortcomings of this criteria as well, as this criteria cannot be applied in all clinical practices, and there is no individuality in this criteria. You cannot, because subsequently in the subsequent slides we'll be referring to the various factors that determine whether the patient will have treatment resistant schizophrenia or not. So that individualism is not present as per this criteria. So this is why this is not widely accepted that much. Now the key features of treatment-resistant schizophrenia: there should be persistence of clinically significant positive psychotic symptoms despite adequate trials of antipsychotic medications. Failure to respond to the adequate trials of at least 2 different antipsychotic medications, including at least 1 second-generation antipsychotic. The antipsychotic trials must have been at optimal doses and for an adequate duration, usually at least for 4 to 6 weeks. Adherence to the prescribed antipsychotic medication must have been documented. and potential causes of non-response such as substance use disorders or medical comorbidities must have been addressed and excluded. So so these are the features of treatment resistant schizophrenia. Now what is the prevalence? It almost affects 20 to 30% of individuals with schizophrenia, and most cases are identified within the first year of illness onset. Now, these are the factors which influence a patient and determine whether the patient will have treatment-resistant schizophrenia. First are the biological factors like altered dopamine signaling, changes in the brain structure, genetic wherein there is family history of schizophrenia or treatment resistance, which increases the risk of the individual having treatment-resistant schizophrenia. Environmental like early life trauma or prolonged stress, substance use, particularly cannabis or stimulants. Then we have treatment non-adherence. A lot of times patient comes and say that they are not improving, but on further probing and interview, we realize that there has been non-adherence to the treatment. They've never taken the treatment up to the optimal dose and for the optimal duration. So there is difficulty in maintaining consistent medication intake due to side effects, stigma, or lack of insight into the illness. And misdiagnosis and comorbidities, which like conditions like schizoaffective disorder, bipolar disorder, or personality disorders, they can complicate the treatment response. Then we have the psychosocial factors like lack of support system, limited social support can hinder treatment adherence and overall recovery, which is something for the current trends. The focus have been drawn to psychosocial support as well. And stressful life events like major life stressors can exacerbate the symptoms and interfere with treatment response. Substance abuse, poor insight and motivation. Lack of awareness of illness or motivation to engage in treatment can also hinder the progress. Now, critiques of the current trends. Whatever that we're using currently and whatever that was used in the past for the treatment of treatment-resistant schizophrenia has its own critique. So, first of all, there's lack of universal accepted definition. Like I chose two of the major definitions, but if you look at it, there are many definitions. And even from a clinician's point of view, every clinician has their own accepted definition of treatment-resistant schizophrenia. Then there is limited treatment options also. Challenges in early identification. It becomes so difficult to identify at the earlier stage whether the patient is going to go into treatment resistance or not. And there's a need for personalized treatment approaches because there are a lot of factors like the genetic and the biological factors which are very personalized. So we need to have approaches which are personalized as well. Importance of non-pharmacological interventions also, and then ongoing research and development. Now, how do we diagnose treatment-resistant schizophrenia? First of all, we make a diagnosis of schizophrenia based on either the ICD-10 or DSM-5 criteria. Then we start the patient on second generation, particularly second generation antipsychotic, and we give a trial. We go up to the optimal dose for about 4 to 8 weeks. If the patient responds, then it is good. If the patient still not responses, then we add another drug, which is another second antipsychotic from another class. And we take that patient when we give the trial also for about optimal dose trial for about 4 to 8 weeks. And then if the patient responds, then we continue the treatment. And if the patient does not respond to that treatment also, then we go for then we diagnose the patient as treatment-resistant schizophrenia. The drug of choice for treatment-resistant schizophrenia is clozapine. We give a trial for 4 to 6 weeks. If the patient responds well, but then if the patient still doesn't respond, then we have the recent advances, which we will be discussing in the subsequent slides. Now the assessment tools. Rating scales like PANSS and BPRS can be used to understand the progress and the prognosis. And cognitive and functional testing can be done on the individuals to understand whether they are responding to the treatment or not. Now, before clozapine, what we used to do in past when clozapine was not introduced into the market, so there was high dose, the psychiatrists, they used to give high dose atypical antipsychotics, or they used to go for electroconvulsive therapies. Polypharmacy was also known, wherein they used to prescribe a lot of antipsychotics, even from the same class. Multiple antipsychotics from the same class were prescribed. Long-term hospitalizations were there. Prior, we are aware of the fact that about the we are aware of the formation, a foundation of mental asylums, wherein the patients with treatment-resistant schizophrenia were kept, and they were kept till their last breath. And psychosocial interventions were also done, but they were not as vigorous as they are being done right now. And experimental approaches were there. A lot of experimental approaches, a lot of new drugs were tried on these patients, a lot of new methods, new procedures were tried on these patients in order to treat their treatment-resistant schizophrenia. And currently, once the patient is diagnosed with treatment-resistant schizophrenia, so first of all, obviously, our major motive is to rule out the cause. In ruling out the cause, we have to redo our interview in order to see whether our diagnosis is right. There's no comorbid diagnosis along with it. There's no comorbidity in the patient. We have to make sure that the patient is adherent to the medications, patient has insight, has a good psychosocial support. Ruling out all of that, we send for CBC and then we start the patient on clozapine. Clozapine is available in 25 mgs and 100 mg tablet, scored. The initial dosage is 25 mg, 1 or 2 times daily. And although conservative initial dosage is 12.5 mg twice. The dosage can be increased gradually to 300 in divided doses, usually 2 or 3 times a day. And we can also augment. And current trend is also about augmentation strategies. Though we start with clozapine, but we can also try to augment. If the patient is not responding to clozapine alone, we can always augment it with aripiprazole, and we can also try adding mood stabilizers like lithium or antidepressants to address the specific symptoms. If we have redone our diagnosis and come to and understood that there is some other diagnosis also, so we have to um, address those specific symptoms as well, which might also help in treating the patient. Now talking about the others. Now this is somewhere a line which is drawn between the recent and between the future. This is something which has been done recently, not that vigorously, but the future holds a lot of prospect for these methods. So we can, non-pharmacological methods along with and brain stimulation, which is done recently, but we don't have enough data for this. But there's active intervention being done in these in order to understand their importance in the future. So in non-pharmacological, we can go for cognitive behavioral therapy for psychosis, social skill training, family intervention, supported employment, psychoeducation, and occupational therapy. Brain stimulation, we can go for electroconvulsive therapy, transcranial magnetic stimulation. Now talking about the future, what the future holds for us as psychiatrists, and what the future holds for the patients who are suffering from schizophrenia, and more so for the patients who are suffering from the treatment-resistant schizophrenia. First of all is the biomarker discovery. Now the main objective is to identify any biological markers that can predict the treatment response and differentiate TRS from other schizophrenia subtypes. Approaches are mostly for the genetic studies to uncover specific genes which are linked to the resistance, neuroimaging techniques like MRI, PET scan, fMRIs to detect structural or functional brain abnormalities, blood-based biomarkers including inflammatory markers and neurotransmitter levels. Then this is a very important thing, personalized medicine, which is something which is being addressed not only with respect to the treatment-resistant schizophrenia, but with respect to psychiatry as a whole. Now, as psychiatry is progressing and we are seeing the new age of psychiatry, we are focusing more on personalized medicine, wherein we have a tailored treatment which is developed for the individual, and there are plans which are based on the genetic, neurobiological, and clinical data. And then we have pharmacogenomics, wherein we are studying how the genetic differences they affect the drug metabolism and response, optimizing the drug choice and dosage to minimize the side effects and maximize the efficacy. Novel pharmacological therapies. Now there are a lot of new pharmacological drugs which are being introduced into the market, And like the drugs which are acting on the glutamate system, especially the NMDA receptor modulators, which address the symptoms resistant to dopamine blocking antipsychotics. Modulators of GABA and serotonin systems are also being studied. Anti-inflammatory agents are also being studied because in one of the studies it was said that schizophrenia is actually an inflammatory disease, which causes inflammatory damage in the body in a longer run. So therefore, anti-inflammatory agents are also being studied for that. Psychedelics and entactogens are also being studied, which are controlled trials of substances like psilocybin and MDMA are exploring their potential to reduce symptoms and improve cognition. Cannabinoids are also being introduced into the market, and then we have clozapine alternatives. Brain stimulation techniques like ECT, then we have the repetitive transcranial magnetic stimulation, we have deep brain stimulation, we have transcranial direct current stimulation. So these are also being brought into the practice. Psychosocial interventions like digital health technologies are being there. Virtual reality is being used in order to instill some sort of insight into the patient, in order to make sure that the treatment adherence is met, and enhanced cognitive behavioral therapy is also being done via the psychosocial interventions. Then we have long-term care models wherein we have integrated care, we have community-based programs and peer support systems. Prospects for research. It is still a very naive topic. We have a lot to achieve, but we somehow have understood the direction in which we are supposed to move. So for the prospects for research are like larger multinational trials, collaborative studies to better understand the treatment-resistant schizophrenia in diverse populations, longitudinal studies monitoring patients over time to identify early markers of resistance and long-term outcomes, artificial intelligence. Using artificial intelligence to analyze big data from genetic, imaging, and clinical studies for predictive modeling. Artificial intelligence, the future. It was said that about a decade ago, people thought that artificial intelligence will never come into play as far as medicine is concerned. But over the past decade, we have seen how artificial intelligence has come to help in the medical fraternity. And then there was a word which said that psychiatry will never be affected by artificial intelligence because ours is a branch wherein it is about empathy, it is about patient care. We have so, but thinking about artificial intelligence, it is said that the future is it's not the artificial intelligence which is the future, it is the doctor with artificial intelligence who's the future. So artificial intelligence will help us in early detection and prediction, personalized treatment, drug discovery and development. It will help us with system monitoring and management, cognitive and social functioning, ethical considerations. We had a lecture on artificial intelligence before as well, in which it was discussed how the avatars are being used, how models are being used for geriatric care as well as the child care. Similarly, we can use these avatars and in order to instill insight into these patients, in order to provide awareness amongst masses and to ensure that there is good treatment adherence via the artificial intelligence and the use of avatars. I would like to summarize my seminar by saying that the advancements promise a future where the treatment-resistant schizophrenia is better understood and managed through precision medicine, innovative therapies, and holistic care models. There's a lot to be studied yet, and still, it is the upcoming topic. These are my references. While going through my references, in one of my references, it was said that having negative symptoms is said to be a predisposing factor for developing treatment-resistant schizophrenia. But there is no solidifying study for that. So it is still under research whether having negative symptoms will be for sure marker whether the patient is going to have treatment-resistant schizophrenia or not. But currently, the criteria which we follow are more so on the positive symptoms. We focus more on the positive symptoms in order to form the diagnosis for the treatment-resistant schizophrenia. These are my references.